key details of today's agenda. Oh, thanks for starting recording. I'd like to begin by doing an acknowledgement of country. We acknowledge the traditional custodians of the land on which we all gather today. We pay our respect to elders past, present, and emerging, and extend our respect to all Aboriginal and Torres Strait Islander people. We acknowledge the First Peoples as the first scientists, educators, and healers. So this is the agenda for today's meeting. It's quite a packed agenda, and we will kick off as we usually do with our usual business and updates. We'll then have Tim Panaho with us doing a bit of an update on the EU Patient Summary testing coverage update work. So this is in the sequence of the Spark testing event a couple of weeks ago here in Brisbane. After that, we'll have Danielle taking us through or doing a walkthrough of profiles. And in this case, she'll be focusing on PS composition, part 1. After that, we will be going through some conformance items. So we'll be focusing on missing data and empty sections and suppressed data. And again, Danielle will be taking us through this. We have an entry here in the agenda, an item here for the use case feedback. And we'll try to get to it, but it's possible that we might not be able to due to the fact that the previous items might just overrun a little bit, given they're quite dense. So they're just flagging that we might not get to this one, and then we'll finish with the next meetings and next steps. So just a quick reminder of the timeframes that we're working to. Key things here to call out is that we're targeting a ballot for comment period, which will run from the 11th of August to the 7th of September. And we currently have the 4th of August as a date. We're planning on publishing the ballot for comment snapshot of the FHIR IG. So this was originally on the 9th, or expected to be on the 9th of August, but after advice from HL7 Australia, this is now the 4th of August. So some things are being brought forward by one call, really, by trying to hit these new dates. Just also a quick reminder on the release 1 scope. We're trying to wrangle for this piece of work initially. You will see highlighted in green the profiles that we've already kind of gone through and that we've had walkthroughs for. The ones that are kind of highlighted with a magnifying glass and a little gremlin bug are the ones we're asking participants here in this call to have a look at. Go and do a checking of them, make sure they're all good to go. And if you spot anything that's not looking right for you, just let us know. So we're just highlighting them as potential things for you to focus on, but also noting that some of them here will still be subject to walkthroughs as part of these patient summary sessions that we run every 2 weeks. So moving on to our usual business, the first item we have here is the approval of the minutes from the last meeting. Sorry, I'll just get them on my screen very quickly and scroll through them. Hopefully this can, and thanks Shelley for pasting the link on the chat. So the meeting minutes can be found in Confluence, like all the other ones before this meeting. So hoping that you had a chance to have a look at them. But I'm probably just going to ask if anyone's got any issues or anything they want to flag in regards to these meetings, this meeting minutes. Sorry. don't see any hands or any comments in the chat. So I'd like to propose that we then move on to submitting a motion to approve this minutes. If someone wants to submit one, please.
I'm happy to make a motion to approve the minutes.
Thanks, Danielle.
To second that as well.
Thanks,
Ricardo.
Thanks, Tim. All right, I'll just launch the poll now. Okay, if you're not able to vote on this poll, just drop a comment in the chat, and we'll count it towards the final results. Okay, I think we've got some solid numbers here, so I'll just now we'll just come through. Well, now in the poll, I think the numbers have stabilized a little bit. So I'll just read the results. So we have 14 affirmative votes and 6 abstain, which means the motion has passed. Thank you all. Just roll this back, and I'll go back to sharing my screen. Okay. Okay. Some updates and news as well that we wanted to kind of flag in here. So the first one is about the Connectathon event in Brisbane on the 1st and the 2nd of September. I believe this is a full, event at the moment. But if you want to go on the wait list, if you still want to participate, just make sure you email events@agile7.com.au to go on the wait list. The ballot sign up is open. I'm assuming you would have received an email from Agile7 Australia also with instructions on how to participate and sign up to participate in the ballot. So if you're interested in participating, just please follow the instructions highlighted in that email. There is a e-vote out to add an Australian public hospital coverage type on AU base. So if this is something that you're interested in, please go and follow this link that's here on the slide pack. We can then put this on the minutes, and you'll be able to access these links a little bit more easily. This is the next one here is just something that comes out of Estonia. It has to do with FHIR validation tools. I don't know, Danielle, if there's anything you want to mention in here about this one, just to get people a bit more interested in potentially checking it out.
Yes. So there's a really interesting survey put out from Estonia, who's doing fabulous things in the interoperability space at FHIR as they move across from V2 and CDA. And they've released a really interesting survey, and they're going to publish that publicly so we can all get the value out of it. And I thought that we should just draw the attention to people who can contribute to that around how FHIR validation is happening, or maybe more importantly, not happening, where things are going wrong, where things are going right. And then we can get the results out of this from everyone around the world. So it'd be great if a whole bunch of implementers in Australia contributed to that as well, as I know there are already other kind of jurisdictions contributing. We'll try to pop that link in the chat.
Thanks for that. And the last one here is the IPS block vote 11 that's passed. So if you're interested, you can follow this link. So just a quick note around the types of changes that have gone through. So editorial and informative changes. Plus one change to note is addition of immunization recommendation resource to the plan of care section. If you're interested, let's go and have a look at it. Actions. So this is a bit of a stock take of actions from previous meetings. So there's a first one here from the meeting on the 13th of June with Danielle. I'm not sure if you have any updates you want to provide on
Yes, absolutely. I've not done it. I'm getting to it very soon. We've prioritized some of the normative stuff, some of which we're sharing today because IPS is a moving target. It's all really around composition at the moment. But it's on the to-do list for the informative updates to AU Patient Summary. I should report back at our next meeting, which is our final one, to go, it's done, here's what it looks like, but it's not there yet.
Thank you. We'll note that. And the other two...
I think actually
the
16th is done. We needed to take that back, and a number of items we've taken back to the IPS group that are in tickets that are being talked through and worked through in block votes 12 and potentially block vote 13. So I would count that as done from our perspective, that we've had a look at it. Not contact relationship. Heath's away. I'll need to double check with Heath why what I assume is patient contact relationship is interesting. From a conformance perspective, I don't know enough about that to comment on it.
Okay. So we'll update them accordingly. Thank you. And just before we move on to the next item on the agenda, I just picked up something on the chat from Brett, which is quite important, I think, with regards to the Connectathon. It's not just going on the wait list. If you register, then if you secure tickets and you can no longer attend, just let the HL7 Australia team know so they can release those spots to someone else who might be interested in attending. So it's good call out, Brett. Thank you. All right. So we're now going to go over to Tim, who will take us through the Australian Patient Summary Testing Coverage update. So over to you, Tim. Thank you.
Cool. Thanks. And Roberto, can you jump through the slides for me so I don't have to share? I don't trust my sharing capabilities in Zoom, and I don't want to stop the meeting. So I understand it's a jam-packed session today, so I'll try and step through this methodically and quickly. But here we can see that, you know, from the testing events, and I had complete FOMO from missing out on going to the event. So, but the team has told me from the agency that it was a really good and very well planned through event. We had 11 different products submitted from the different organizations that you can see there during that event. It was a really great to have the level of coverage from different systems and products within those systems. So appreciate the continued efforts of each of the vendors here, and you know, we'll hopefully get more vendors as they come in. As I wasn't at the event, and maybe on the call there are people that were at the event, would like to put their hand up and just sort of see if there's any feedback or comments that people wanted to sort of run through. I think you know, from my perspective, the team said it went really well. There's a lot of engagement there, a lot of people testing results as well. So that was really good. If no one wants to sort of jump in or talk.
I don't think we have a representative from them, but it was really interesting to see some of the use cases from Patient Summary coming across into other contexts. So the Scripty app and OX and what they developed in terms of connecting and looking at how they can populate an active script list for a patient, given access to different sources of information from a patient. So hitting the front end provided from ADHA, hitting the Halo Connect, area, and they pulled that through, were able to populate an active script list from the patient summaries using different methods for that. And the patient was also able to see the patient summary within the Scripty app. So that's just one that kind of stuck out in my mind as being a really cool thing that was delivered on the day. And so I think that was really exciting from the agency, Halo Connect, and best practice and OXA from that perspective.
Amazing. That's really inspiring to hear and exciting to, see what there's opportunity is at. I know in Adelaide we got to see some of the examples people were sending through as well, which was really cool. And now seeing it from a testing perspective is even more, is getting closer and closer to achieving, some of that great sort of involvement there. Jump to the next slide, Roberto. Thank you. And as we can see here, we've got, just the coverage of all participating systems, testing those specific resource elements, those profiles here. And we can see that there's been a jump with the green arrows on from the last Connectathon, which is really great to see. We do still note that there is, because this is quite new, in terms of being able to test, there are some deficiencies there around related persons and composite, but it's quite good to see that dollar summary was tested. Some of the other statements and profiles were tested here as well. And I guess the message here is that we're doing a little bit of a call to arms for the next testing event. And we'll probably be looking at the community and the vendors to come prepared with a little bit more of these profiles as well, so that we can sort of get more coverage as we go into it. And yeah, that would be sort of fantastic to see there. So if you jump to the next one. Here we can see just a brief outline of what the percentages of coverage were between the systems. So if it's a solid green tick, we can see that more than 3 systems tested 100% of the must supports and the mandatory elements and the conformant requirements within that profile. The lightly grey green tick is we had between 80 and 100%. Which is still great, right? That's the effort that was put in here and the ticks that we received here was a fantastic event. And it's like, as we mentioned yesterday, if you're in the TDG yesterday, that that's nailing it. We're really seeing some good uptake in there and some great coverage. The orange ones are less than, and probably because I'm not quite surprised from a patient summary perspective, because it is new and was sort of getting more involved in it, that there is less coverage there. And moving forward, we'd be looking at more examples and trying to get more of that activity happening for coverage within our vendors to get across that. So that would be, just noting that.
Can I just make a comment here about composition? People might be really confused why bundle is fully covered, but composition is orange. And to be honest, I think it's probably going to stay orange. Every section in IPS and AU patient summary is based on IPS, is must support. And that includes patient story, it includes alerts, it includes care plans, functional status, and a whole bunch of things. So it's really quite comprehensive. We might want to look at reporting that across maybe common sections versus other ones as well, to make it kind of clearer when we're doing it. From a flat percentage count, I think it's very unlikely that in this first kind of look at implementing things in Australia that we're going to have more than 3 systems implementing covering all of the sections. So we might have a look at that.
Yeah, and I'll put a call out for the agency as well to help sort of provide coverage within these as well as we go. Thanks, Roberto. So we'll jump on to the next.
You owe me three coffees now, Tim, for calling me Roberto 3 times.
3 types of coffee. Jump to the next slide. Thanks. And just to go into a little bit explanation of this one. So we can see at the top the allergy intolerance. We had the full coverage there. That 10 out of 10 systems, 9 were flagged as mandatory supports that were tested, and 3 or more of those systems test that profile to 100%. There's more granular detail into what that looks like down. And if you just go to the link there, I'll just copy and put it into the chat. Oh, no, it won't. Yeah, it'll take you to the actual test results that were sort of put through there. So, sorry. I'll put that in the chat now. You can also see the other ones there. The composition is, Danielle rightly points out, there's 86 of those physical fields or elements within the profile that need to be tested and covered. And we had 6 systems test, up to 32 of those. And so that's why you're seeing those percentages there. And hopefully next time as we get more into this, or maybe there's a reason why we're not covering it, we just get that visibility there and track and report it based on certain elements in that perspective. And I guess, Danielle and Ricardo will be seeking to get more support within the next Connectathon for Patient Summary. I haven't really got any notes around that, but I assume that when we do our next test, it'll be quite useful and helpful if vendors can come prepared, maybe with some more of these type of activities.
Yeah, I think that's the conversation we'll have in August. So we'll work through the content for ballot for comment. Then when that's happening, I think part of what we want to do is look forward to what do we want to take into testing for the rest of the year, and whether or not there are any things that we want to add in and explore around exchange, or whether they're particular resources or use cases. So yeah, I think that's the call of what we'll be doing in August till the end of the year.
Yeah, cool. Excellent. And as we can see on the next 3 slides, actually are the elements that we're looking at fully covering within the release there. So allergy intolerance, the bundle, the composition, condition, encounter, immunization, medication request, and statement. If you flick to the next slide as well, Roberto, you can start seeing that trend and where we're going with this and the percentages of what's being tested. And if you flick to the last slide there, it's just around the interactions and some of the search.
Hang on, could you go back?
Sorry. Yep.
That's fascinating. I'm gonna have to follow that up. 1 system tested practitioner role, but we're going. Oh no, I follow it now. The 0% is about greater than 3 systems. Yeah, sorry.
Yeah.
I was just going, how did we test nothing? But I'm with it now. Okay.
Whoops, did I swear? Apologies. There's definitely a lot of copies that I owe for.
It's for calling me Roberto, Tim.
Oh gosh, darn it again! I don't. That is definitely a swear moment. Ricardo, sorry. Absolutely. Last slide there, 100% is for the bundle reads, which is just a read, and that's pretty straightforward. So, yeah, back to you, Ricardo.
Thanks, Tim. Yeah, look, quite interesting, and I was there on the day, and I could really say that it was a very good, very good day. Lots of, great to see all the technical brains coming together and the testing things, furiously. So yeah, it was very, very good. And for me personally, it was the first time, I've been involved with something like that, and just being able to put something forward and just seeing it kind of come to life in the sense that others were able to integrate with it. Just took it to another level. So really, really good. Thanks for that, Tim. Now over to Danielle, who will take us through another profile.
Yep. Thanks, Ricardo. Thanks, Tom. Do
you want me to keep flicking through the slides?
I should probably take over anyway, because I'm going to need to share my screen to do the profile. So Let me just click that button. Okay, I'm just getting situated. I know there's about a second delay or so on this, but you should be able to see my screen
Yep,
now. All right, so going back to where you were, for those of you who attend these regularly, it's the same slides because we're still doing the same thing. We're reviewing profiles and we're walking through them. Part of this is because there's still a window that is open in AU Core and IPS. We're based on both of those, so almost all the requirements that we are putting forwards in AU Patient Summary are from IPS or AU Core. And so we want to also examine what does not make sense from our perspective and feed that back into IPS. I can say we have representatives from this call who are in the weekly IPS calls, who are bringing the concerns up to them. And in the voting meetings, the vote for one of these for block vote of 11 was this morning at 7 a.m. If you ever want, please do join. But yeah, they're on, what's today? Fridays? Yep, 7 o'clock in the morning. So this is the kind of thing we're looking at. What is currently in there? Why is it in there? Do we want any additions? What are our problems? And giving us the feedback that we can take back to the AU core group while they're working through R2 to change anything we think is a big problem. And the same with IPS, to feed things back in and go, hey, we really don't think that this obligation or this conformance requirement should be applied. And we have successfully, I should give stats on that at some point, but a whole number of Australian representatives, not just from this call, also from the agency, have been very successful in providing a lot of feedback into IPS 200 and making a lot of substantive changes. But here's where we are. We're on composition finally. And this is part one. Composition is big. It is by far the largest profile. It's going to be at least a part one, part two. I suspect we'll go into part three, especially if we want to treat this a bit more like an information session and maybe have a few more questions and leave it open for people to go, well, what does that really mean? I'm quite happy to take that approach. And that just means that we'll just keep continuing through it until we've looked at it all. Quick recap, show this slide every time. These are our profile design principles. We've agreed to be compliant to IPS and core. And that means that our profiles are designed to be the fully calculated set of rules across IPS and AU core. And that the reference elements, so where it like references an author or a subject, is against an AU patient summary profile, because that target profile is the one that also incorporates the IPS and AU core rules together. And when it comes to terminology, we prefer the AU core sets because those incorporate the AU CDI, as in the Australian localised set of agreements around the Australian clinical reference sets that are published in the NCTS, the National Clinical Terminology Server. I'm going to move past this. Let's have a look at composition. There is one variation or a couple of variations. I'm going to call them out as we go. It's almost entirely, because there's no AU core profile for composition, almost entirely the same as IPS. There's a couple of notable differences. All the profiles it references are to our profiles, AU patient summary. And the other is, in Australia, we have a pattern of setting must support on mandatory items, including conditionally mandatory. So we'll come to that. Yes, skip verification. All right. I might make that a little bigger. So there's a lot to go through. I thought that for the first part that probably the people on the line were less interested in the header and were probably more interested around, but what do I actually have to do in terms of these sections? But I'm going to pause here for a, where would you like me to start? There's going to be a lot to go through. I think it's probably I've assumed that people would be most interested here because that's where I get all the questions, whether we're in events or online. But does anyone have a particular question or something they want me to focus on in this walkthrough? Is there something in the chat? I'm not monitoring it. No. Chris.
I felt sorry for you because no one's asking questions. So I think it'd be nice to know the empty status, the lack of information in that section.
Righto. Okay, so there's a couple of things. That's going to be a big part of what we're going to come to an agreed proposal on later on. But from a syntactic perspective, as in on the wire, we are largely adopting IPS's approach. And that is, in terms of sections, and if we're really just talking about emptiness at a section level, not emptiness on a single element within a resource, they're different things, but empty sections, we all have this requirement we've inherited that 3 sections are mandatory. They are the ones that are in IPS, and we have a matching kind of, we've inherited this, where there are 3 required sections. Then there's 4 optional sections. 3 required sections have a cardinality set to a minimum of 1. This is the same in IPS as AUPS. All of these sections are optional. The difference in the structure is obligations. Recommended sections versus optional sections have a different set of obligations. The recommended ones are stronger on a producer of a patient summary document, and the optional ones are, well, there are none. Actually, that's how they've done it. So they've said, this is a shall, you got to do this. This is a should. This we're going to be quiet on, which is a may. Everything we don't prohibit is a may, because these are open profiles. And so what that looks like coming back is a combination of the cardinality and the obligations. So we pop back to sections. And quick profile overview for those of you who don't look at these things every day for hours like I do. This is an element. It's a repeating element. The minimum number of these is 3. They are going to be these different sections. This element has been sliced, so we can say specific things. And we've got a few different breakdowns of the slices. We've got one that is all slices. And so what sits in here are the rules that apply to every slice. All of these, and it also applies to undefined. It's important to note that patient summary specifications, IPS and AU patient summary, define a number of sections, but they leave this open. So see, this is in terms of slicing where it says open, so it's not closed. The intention here is we all understand that there are reasons for systems to satisfy workflows to provide different information than what is defined here. And so you can define your own section and provide other ones on the wire. But if you do, every section has to meet these requirements. And these requirements start with this, which has no must support on it. It's just defined that you could possibly have notes here. This was talked about in the testing event, by the way. This was being used for capturing updates to summary information. So allowing annotations from clinicians or from patients onto existing information to add further comments. So that was an interesting use, and that was Alcidion that was providing that. And they were using this extension. But this is available on every section. Title is mandatory for every section, but we say nothing more on it. I mean, you shall populate if known. So you have to provide something there. Text is also mandatory. That's the human readable narrative. Every section has to supply something in text that's expected to be the summary of what's in the section for human interpretation. it may have more content than what is in the structured data. That's allowed. And there are ways you can say that using this data type. So then we come into these particular sections. Now, there's different rules around emptiness for whether a section is mandatory or whether a section is optional. So these ones say there's a rule, IPS Comp 1. If we pop right to the end, IPS Comp 1 here. So the rule is that when you're populating one of these sections, you need to provide an entry, as in you need one or more condition resources or allergy intolerance resources, or for medications, that's something like a medication request or a medication statement. Or if you don't actually have information, you shall populate empty reason. This is true emptiness. It's distinct from no-known X. So there's still, if your system has information, you should still be populating section entry. So if you can say a patient has no known allergies, you should still put in, if I just go up to allergies, sorry, that's quite a long way, isn't it? Here, you should still populate the entry with an allergy intolerance resource that says, that has the SNOMED code of no known allergies or whatever fits the circumstances. But if you just don't have any data for the patient, nothing recorded in your system, you need to fill out empty reason. You can't just provide section narrative. I'll pause there for questions. That's, I guess, enforced by the profile with that invariant. You have to provide either this, at least something in the entry, or you have to provide empty reason in addition to providing text. If there are no questions, we can just quickly have a look at the optional sections. Now, we might choose to do something else different in Australia. You'll see we've got must support on empty reason and we've got must support on entry. And that's because we have a rule that says you have to have one or the other. So there are obligations on producers to, if you have this and you have to be capable of it, populate it. But if you don't have this, then you have to have this. If we pop down to the optional sections, so we start hitting this in, here we are, section results. Right now, there's nothing in this view about empty reason. So IPS, and at the moment we have no rules enforcing that structured level of detail on the recommended and optional sections. So we only force structure in the required sections. Here, what you can do is you can have a text or text and entries or text and empty reason, noting that there's no obligations at this point on empty reason. We might make a choice in Australia to say we still actually want to call out that empty reason is really useful. That would be a local thing. IPS hasn't, but from some of the conversations I've heard from people on how they'd like to use this, that seems like something with maybe a should obligation that I think is probably going to come out of ballot. How's that kind of tracking for people? That we force structure up here. Here, it's a choice. You can actually populate a text only area here if you are unable to populate any of these, because this is a should. That's the obligation, is a should, not a shall. It is a system's choice. You could be fully text only if that's all your system can do. You could choose to do these. You could choose to do empty reason or a mix of all of the above, depending on the kind of information you have available in your system. I'll go down past recommended, because you can see here, these are recommended sections. So entries still have must support. It's a should, not a shall, but there's still a must support with obligations on the entries. When we pass this area and we go into the optional sections, which is here down, there is no longer any kind of must support or obligations on entries. At the section level, this holds true, and we inherit the stuff from all sections. So that's the title and the text. So every section, including this one, advanced directives, needs a title and a text. Code is mandatory, but entry or empty reason has no must support obligations at all. So this sits at like may. I think that's probably where we'll stay for Australia. I think these are, I'm not hearing a huge degree of commonality across all the use cases, which matches because that's what IPS has been looking at. So the experience in Australia, I think, has shown that quite a few people have one or two of these extra sections, but it's not really that common that everybody is looking to support all of these different sections. So I think that makes sense. But again, we might see some things surface out of the ballot for comment that look to place further obligations. And you'll also even see that at the section level, there are only consumer obligations. There's no expectation at all that a system that is producing a patient summary document does anything with this. There is an expectation that if a consuming system says, I can consume patient summaries, that they are capable of consuming this section. And that might mean they persist some of it or just ignore some of it or straight display or however that works. But there are expectations for each of these sections for consumers, but not producers. Does that answer your question, Chris? And if not, we can, how are we going, Ricardo, in terms of time?
We're still okay.
How much time do I have before we need to move to the conformance section?
I reckon 10 minutes stops.
Okay. So overall, that's how to read these sections. There is an invariant on the mandatory ones. So you have to supply a problem section. And with this invariant we inherit from IPS, you have to supply at least one entry, could be as many as you want. Or if you don't have that, you have to supply empty reason. And due to the requirements on all sections set here, that you also have to supply title and you have to supply text. And those are your requirements. Obviously, there's also code, and the code is fixed for each section. For downstream systems, so people who already have different sections, I'm just going to call one thing out for you because it's really quite important if you're going to be doing this. The discriminator of the sections is code. So it's not title, it's not text, it's not entries. How we know which section is what, like is something the problem section, is something the alert section, is it the advanced directive section, is by code. So when you are looking to derive or define for your own implementation, and I know people are absolutely doing this and it's a legitimate need, that there are additional sections that they need to define and share with other people, you need to have a code. Basically, you need to define and agree a code. And obviously your title and your text are mandatory. After that, it's up to you what you do. You have to have title, text, and code. All right. I'm going to move off this and go to our conformance proposal because I've gotten the update from you, Ricardo, in the chat. We'll hold this walkthrough there. I think that was a good kind of overview of how to read these different sections. And we'll come back in our next call and cover off a few more parts. And if people have any questions that they want me to walk through in our next meeting, you can either post them in Zulip or you can email me and I can prepare towards that and we can run through them in our next fortnight. So, conformance proposal, same kind of thing that we're actually talking about, which will be about emptiness. I know I'm kind of jumping ahead here, but so we have run through 6 conformance sessions. And we went and voted on the first part of the proposal in our last meeting, and that passed. And in last Friday, we got back together again to look at the proposal around missing data and emptiness, empty sections, and suppressed data. And we worked through as a group what we thought would be appropriate to put out for ballot for comment. I have taken away and revised that, and I'm presenting that today. Thankfully, there are several people on the line from that call, because if I've misinterpreted one thing or left something out, I'm looking to you guys to put your hand up and call out where I might have missed our conversation. Background, we'll skip past that. We already agreed on this. These are our profile design principles, which you already saw. Here's our must support and obligation principles. It all boils down to we satisfy the IPS conformance expectations, and we also satisfy the AU core profile only expectations. That means we are at least as strong as AU core and IPS, and we can sometimes provide additional guidance, or we can choose to strengthen some things, but we can't be weaker or we won't be compliant to both of those specifications. So here's the part we're talking about. These 3 points down below. We agreed that these are the conformance obligations for a system that produces patient summary documents, and in particular, an Australian patient summary document. So you shall implement the requirements on suppressed data when an element value is not allowed to be shared. And there's an addendum to this I'd like to make. And there's shall implement the requirements on missing data when an element value is not known. And the third part is shall implement the requirements on empty sections when information for a section is not known. The addendum I'd like to make is that we discussed last Friday what to do when a section is suppressed. So when only it's an entire section that's not allowed to be shared, as opposed to an element. And so we've agreed on a set of guidance on how to do that I'll put forward today. And if we agree on that, I will come back and update that point to say when an element value or a section is not allowed to be shared. Consumer is just, you can consume things that have this information. It's kind of boring. Here is kind of the set of things we're going to talk through. Now, what we've kind of split this into, missing data and empty sections, we've actually kind of broken that down into 4 things. There's assertion of known absence of data. So that's no known X, no current medications, no history of procedures. IPS, AU core, US core, we all need to say things about how you represent that because it's still important information to share. Then we've got known absence of data due to workflow. There's been a lot of work that's been done in AU base over the last year on how to do this within Australia, and that's proposed that we provide guidance on how to do that in Australian patient summary. Then there's missing data and just empty sections and suppressed data. So if we bit more detail, the assertion statement of known absence of data, this is at a resource level. Like you basically have a resource that says, and what's important to note here is your system has something in there, and that's what you're populating with. Your system has some information, like it's recorded somewhere the patient has said they have no known allergies, or a clinician has captured some information about this, and that is what is populated. The known absence of data due to workflow, we've currently discussed how to do this at a section level. So we can say that a system has some information captured and can populate, but this is around why you don't have this information. Like it could be a not asked or a prefer not to answer kind of thing. The last two, we're differentiating here missing data and empty sections. Missing data is where an element within a resource is missing. This is really what's been defined in US Core, AU Core. It is also how RPS has done it. So we're just going to carry this through. We are saying missing data. That term is what we associate when an element within a resource is missing. And a system doesn't know why. So you just don't have this data, basically. Empty section is where the section information is missing. So it's not a single element within a resource, it's where an entire section. So you just don't have allergy information for a patient, and you don't know why you don't have allergy information. It's not that you have something that says they have no known allergies, it's just you don't have anything. So that's empty sections. How is that kind of breakdown working for people? Have I missed anything that someone thought would really be addressed by missing data and empty sections that I haven't called out? No, and of course, we've got the ballot for comment. Really what we're putting out as a baseline for a direction on where we think we've got some a baseline for how to do this within patient summaries, and then provide that through ballot for comment. All right, I'll go on. So that's really just kind of working to where saying, look, there's different times you might have information that's missing, and you might have information on why it's missing and you might not. Where data is missing at a section level and the reason isn't known, then you shall implement the empty sections advice. When it's missing for an element within a resource and it's not known, you shall implement missing data. Noting, of course, as I've just talked about, composition section is treated as empty section. I know it's an backbone element, but we're treating emptiness at the section level as empty section, not missing data. And that missing data is distinct. So this is codifying some of that. We can work on the wording later, that we really want to distinguish this kind of behavior. So let's go through missing data. This was looked at in our last conformance session on Friday. There were no comments about it. So I'm just going to get this ratified here, because this is, I mean, exactly the same as AU Core, US Core, IPS, IPA, where there is optional data, an optional element, and it's labeled must support. And if it's missing, you shall omit it. So if a producer doesn't know that value for the optional element, you shall omit it as per these requirements defined in AU Core. Whereas if it's mandatory data, which means the element has to be present, so it shall be present, even if you don't have the information, then you shall apply the requirements in AU Core. We had a look at whether or not we should rewrite them, but there was no need. The guidance is, yeah, it is exactly the same, with examples on how to do coded and non-coded. So does anyone have any questions or concerns about just adopting these missing data requirements. Hearing none, would someone like to make a motion to approve these coming into our ballot for comment? I would like to. Sorry, I forgot I wasn't chairing because I chaired yesterday.
That's okay.
I shall motion. I motion that we approve these missing data requirements for AU Patient Summary.
Thanks, Danielle, and I'll second it.
All right, I'll launch the poll now. Vote for question. All right. As previously, if you're not able to vote, just please drop your position in the chat. Might give it another couple seconds. The numbers seem to be stable now. Okay, I'll now end the poll. Read the results. So we have 16 plus 1. So we have 17 affirmative and 3 abstain, which means the motion has passed. Thank you. Back to you, Danielle. You're on mute if you're talking.
Yeah, sorry. I just had to find the off mute button. All right, empty section. So let's keep going with missing because I think this is the simplest kind of thing. We just did missing data where I don't have this information and I don't know why. It's just that this data just isn't in my system. And the same with sections. If you're looking to populate a section, or rather there's a must support on the section and your system doesn't have this information, we've broken this down, like on the other slide, between optional and mandatory. So here's the first bullet point. So the first point is about optional. So we're saying you should emit. It's not a shall. There was quite a strong preference for this being a choice an implementer can make. And in fact, there were quite a few people between mays and shoulds in our call on the Friday session. But in the end, 60% of our respondents wanted to retain a should instead of a may. So coming out of the conformance session last Friday, we've put before this group to go to ballot for comment with this guidance to say that you should omit non-mandatory sections if your system doesn't have any information for that section and doesn't know the reason it's absent. Are there any other comments or questions people want to make around this point?
Can I ask
right.
what the reason was? Sorry, can I ask what the reason was for May?
Who can I call out? Let me look at the participants, because there are a couple of people who were making the argument on Friday because it was really relevant to how they were looking to implement that. Marika, do you want to have a go?
Yeah, I preemptively unmuted. So for our implementation, we have a FHIR API that then goes and basically talks to 6,000 different GP clinics. Each of those GP clinics might be on a different version of our FHIR API, depending on the version of our software that they're running. And because they'll be on different versions, they might have a slightly differently shaped IPS summary. The way we're implementing IPS is adding sections in a modular fashion. And so our argument for May was basically that in our implementation, if there is a section that we have implemented, but it is empty, we are marking that as like putting an empty reason on that section just to say, hey, yes, you're getting an empty section because there's the capability of data being there, but there is no data available. So we use the term unavailable so that we're not giving any away for and against. It's about having a uniform surface area. And I guess people who are using our IPS knowing, oh yes, they have implemented that section on this site, or no, there is no empty section reason on this other site or this other GP clinic. So it's not, it's probably a version related thing. So that was our reasoning for May, but should also work for us.
Thank you.
All right, unless anyone else wanted to comment on the May, because I think there might have been another system on the line. And thanks, Marika, for providing, I think, a really clear, succinct definition of why that's relevant for you. Let's have a look at mandatory. So same with at an element level. If it's mandatory section, knowing there are only 3, it's allergies, it's problems, it's meds, the section shall be present. So you have to do that. And as per IPS Comp 1, if you've got nothing, what we would prefer you to do is to use section empty reason. So we would prefer this to be really, really clear, and beyond prefer, I guess we're saying shall. So you shall populate composition section empty reason with the code unavailable when there is a mandatory section and there is no information for that patient in your system, and you don't know why the information is absent. Any comments or questions about the rule for emptiness for mandatory sections? I don't know if I heard someone there, but I'll say I think hearing nothing there, and there was no argument against that. Everyone was in favour of it at the conformance session last Friday. I'm going to make the motion to approve these requirements. So motion to approve that an AUPS producer should omit non-mandatory sections, and for mandatory sections, they shall populate the composition section empty reason with the code unavailable from the list empty reason code section.
Thanks, Anil. Do we have a second?
I'll second it.
Thanks, Tim. Yeah, give it a couple more seconds and we'll now read out the results. Okay, I think the numbers are pretty stable now, so stop the poll. And we have one chat from Danielle. So we have 16 affirmative and 3 abstain, which means the motion is passed. Thank you, and back to you, Danielle.
Okay. Okay, so next couple of bits. Suppressed data. Right. So this is not emptiness. In some circumstances, pieces of data might be hidden. There could be a single element or multiple elements within a resource where that information isn't allowed to be shared. Classic examples of that are contact details or address details for individuals. Depending on the surfacing of this, that might not be able to be shared. Sometimes it is actually particular sensitive flags on clinical elements. It can also be at a section where certain sections are allowed to be shared, but certain sections are not allowed to be shared depending on the use case and how it's being accessed. So we've broken this into section and element. And again, we've broken it into optional and mandatory because, of course, if it's optional, you do always have the opportunity to not include it. But if it's mandatory, you don't. So we've got guidance about those circumstances. This came through really clearly in the last conformance session that we wanted to break it up into 4 bullet points around optional section, mandatory section, optional element, mandatory element. So here's, I think, where we got to, that if it's an optional section and it's not able to be shared, we landed on may in our conformance session. It may be omitted, but if it is provided, so someone is actually filling that out, they have to supply empty reason here. Which means they're not actually providing the data, of course, because it's not allowed to be shared. But what you're actually filling out is the section empty reason. You can do either unavailable or withheld. That depends on your system circumstance. Unavailable looks like missing. So that's probably what you're using if you're not allowed to even share that the user is unable to see something that does exist. But if you can flag that, you can always use withheld. So that's left up to the system on which of their choices are. So that's optional. If it's mandatory, then there's no choice. It's not that it's up to you on whether or not you omit it. You have to provide it. And in that case, again, it is up to the system to determine whether they're using unavailable or withheld and populating section empty reason. So I'm going to pause there about the section and say for people, is that making sense? Was there anything else that someone was expecting? All right, I'm going to move on, noting that really what we're doing is putting out a baseline with a clear enough intent that people can comment on this during ballot. So this is not the perfect be all and end all. And I've got a number of improvement comments I know I'm going to be making to some of this wording that'll take a bit of time to wordsmith. Let's go to the elements. So this is straight adopted from AU Core. So optional element shall be omitted. That's the AU Core requirement. If it can't be shared, you shall omit it. If it's mandatory, then you need to choose between unknown and masked. These are the AU Core requirements we're inheriting. So any questions or comments people have on suppressed data? So not hearing any.
Sorry, Danielle. I was just going to say what's not clear to me is the use cases of where this may be used.
That does vary. There are many use cases that I know the agency deals with, especially that depending on the content information is, well, in CDA land, it's masked, where you are still providing information, but you're not able to share a particular element or section there. And so you need a way to not share that particular piece of information while sharing the rest of the document.
So I suppose I'm thinking from a clinical perspective, if it said it needs to say something that triggers the fact that something's not shared, whatever that may be. But then where it gets tricky is if it's something that's in an element that's clear why we wouldn't be sharing it, then we shouldn't, like for instance.
Well, it's not always, oh, sorry. Yeah.
I was going to say like HIV status or something like that.
Yeah, that's one of the known cases. The other is contact details for like people who have access to, if they're a nominated representative, they may still not be able to have contact detail access. So those particular elements would be masked.
Yep. I don't disagree with the concept. I'm just trying to understand when it's used, is it used in a way that still triggers there's something missing? Or does
That
it?
has to be left up to the system business. So I guess that's, to a degree, that's what we're trying to do, is say that that needs to be thought through really carefully in both the clinical workflow as to, if you need to have an alert, you use masked because that will alert and withheld will alert. If it's really important that you don't even let the person looking at this know something was withheld, again, for DVA reasons or something else, you use the code unknown. So we've got the two options there, one that will flag an alert and one that won't. And then we're looking, the system that implements this needs to work through its own kind of clinical safety content on which one it's going to use.
Yes, I understand that, but I'm thinking more around the recipient. I
don't think I have any, because it's at such a really high level of providing options. I think we're going more into, as you're calling out, specific kind of use cases that I think that might be a topic where we look to maybe the clinical design group or have that aspect undertaken, rather than the technical design group trying to kind of prescribe situations.
Yeah, I understand, but if the sender determines how they make that look, it's probably, I'm probably thinking more around the business rules and the use cases behind it, so that they make the right decision, so that the recipient gets the information that they should get, or at least triggered that information's missing in the right way. I just can't.
I think, Brett, you've probably got a comment on that.
Yeah. Okay.
Yeah, I'm kind of saying the same thing as Danielle. I think I think it's a policy overlay on when you apply either of these options. So I think a particular usage you may want to include that policy overlay, but I don't think we'll do that in the standard itself. So I think the options are here, and it does give you the option of letting people know if data exists or not, and that may be different for different sections, and that may be under whatever policy regime is in place. So and that can include like user rights and other things that may play into what you actually get when you request one of these. But I think, once you put it into like a national context and some sort of sharing context, then there probably will be some policy rules on how this works. And but I don't think we're going to define them here.
I think it is one of the hairy questions. I know the CD or the CFG, the clinical focus group, have called out. I know we've looked at this and a number of other hairy questions that have been flagging things of, this is quite important, but these are things that we can't solve in this particular specification. We can provide the hooks to do this in a shared manner, but I don't think we can answer the question. I think they're good questions and they're necessary questions for implementing safe and secure sharing of data. So we could always throw to the agency on the line. Any comments?
Well, probably. I think I'll start by saying that probably not any specific comments about this one. No, I don't think. But I was just wondering if there's an action we should take to potentially circle back to the CDG and CFG on this one and just try to get a bit more of a position on it.
I think there's probably two things on what we're asking them for. So regardless of what way we do it, it won't change this guidance. There's always going to be, if it works for your use case to do to not at all allow it to be known that information is withheld, then this is the code you use. But if in the particular circumstance, and there are a lot of really important ones, you do want to actually say there is hidden data here, this is the code you use. So that's going to hold true. I think we are getting into the wider implementation and national context. So I might talk with you offline, Ricardo, on what we might want to take to the CDG,
And,
and maybe also what the agency can consider.
And I can see Brett's got his hand up, but I'm just going to ask a question. So rather than potentially being kind of too specific and calling out security or privacy reasons, should we just be a bit more open on this one and just leave it at specific pieces of data may be hidden and probably not really expand down to this level and just preempt that there's probably many different reasons why this may happen, and then just leave that to the policy or whatever layer really applies to it.
I don't have a problem with that. I also think that could be a ballot comment. I don't think it doesn't worry me either way, because it doesn't change the material nature, I guess, of what we're putting out to the public to get the next level of direction on. We'll go to Brett and Tim, and then we'll look for that revising of that first statement, and whether that's something that's the revision we want to take in a ballot for comment. So Brett?
Oh yeah, I think the words here make good sense as a how you do it statement, and I think the rest is really context dependent. So like if you point to share or point to point or a user internally inside your system, they're very different situations, and the kind of policies will be different based on a lot of different things. So I think in some ways, like you can go back to the CDG, but that will still be bound to some context of use that they're envisaging, right? So I think in some ways we don't want to really go there. But I think this is really clear in terms of spelling out how you would do it if you want to approach those concepts.
I agree with Brett on that statement there. It's down to the specific use case in your local system. I know that they'll have specific policies and probably legislative requirements to hide data, especially things like vulnerable patients, minors, people in prison. You want to obfuscate certain data elements that are specific to that clinical system. Mental health systems are a classic example where you don't want sensitive information leaving that ecosystem, and so you'd want to be able to present, treatment plans and interventions and sort of progress notes on their behaviors, but you don't want to go down to the level of if they're actually on certain medications or actually vulnerable to certain situations, or actually, it's a family violence scenario. So I think here, this all makes sense to me from a having it perspective, and it looks pretty straightforward for your implementation, and the implementation use cases are probably, many of them.
All right, so quick question before we go to motion. Do we want to revise the first statement to remove security and privacy?
Probably while we're at it, do we also want to maybe swap the word hidden with suppressed or not shared or something along those lines?
I think we're going to let's ballot for comment. Like, we're going to have so many opportunities to fix to wordsmith later on that I think if the intent is clear enough, I think we can put it out. And then I absolutely expect many people to have good suggestions on how we can get this wording enhanced.
Yep, fair enough.
So do we want to remove the due to security or privacy reasons, or is this an important flag to at least take for ballot for comment? I guess that's probably my question to the group on, do we just go, could be hidden? Or do we want to say, could be hidden, and this could be due to security and privacy for the ballot for comment? Which way do we want to go? Or we could put out a quick poll. Okay, I'm not signed in. we could try a quick vote for current motion and tell people what the approve, deny, etc. is. Oh, Ruben.
Yeah, I'm up for dropping security or privacy because those aren't the only reasons that things might be suppressed. And I'm also wondering if the heading of this whole section is suppressed data, shouldn't we be saying specific pieces of data may be suppressed rather than hidden? Because I'm not sure people will appreciate why we're using a different term.
Anything that gets us into the ballot for comment, I am in favour of. And then I can raise a comment if I don't like the wording.
So you're okay to go with suppressed then, Danielle?
Yeah,
Sure.
also happy with what Ruben's proposed.
All right,
Thanks.
so let's say in some circumstances, specific pieces of data may be suppressed, full stop. Does anyone want to argue for for something other than what I just said? I can also put it in the chat. Hang on. Okay, forgive my spelling of suppressed. I always get that wrong. So that's the proposal to change the first sentence. Are there any other friendly amendments or changes that people would like to make for the content that we put out for the ballot for comment?
I guess I've got a question here, Danielle, and that is,
yes,
if we have this statement, then how does this sort of reconcile with non-conformance for missing mandatory data?
Yeah,
quite well. They work together as they have in AU Core and they do in US Core as well. The point of offering a code unavailable is to, since we say something is missing data, that's why we use the code that looks like missing data. So when you are not allowed to even tell a system or a user that data is actually masked, you're essentially using the missing data values. So they work together in synergy in that way.
Okay, that's fine. I guess, and maybe this is the point Grant was trying to make earlier on, is the code of withheld. It's good that that's an alternative to unavailable, because I think in some circumstances, even asserting that things are deliberately withheld won't meet policy muster. So that's fine.
Exactly. Yeah.
Yep.
Yeah, that's why we've got the two options. And it's up to your system to know which one you are supposed to be putting forth to meet with your own policy requirements.
Yep, I'm happy with this wording then.
All right, so I'm going to make a motion to, with the amendment of that first sentence, as I put in the chat, that in some circumstances, specific pieces of data may be suppressed. Motion that we accept this set of requirements for suppressed data.
Thanks, Danielle. Do we have a seconder?
I'll second Millie from Haler.
Thank you, Millie. Yep.
Hugo, you might need to go on mute. Thanks, Hugo.
Oh, right. I think the numbers have stabilized quite a bit. I'll give it another couple seconds before stopping ending the poll. All right. Thanks, Danielle. I'll end the poll now. Okay, so we have 15 affirmative votes and 4 abstain, which means the motion is passed. Thank you, and back to you, Danielle.
Okay, we've got 2 more things. We might run 5-10 minutes over time. Apologies for looking at the last 2 aspects. We can also move them to the next meeting if we need to, but I think we're talking about the same thing, so it would be really great if we could get these done around how we're dealing with emptiness and missing data and things like where there's no known X. So we've got through 3, we've got 2 more. And this is where we actually have an assertion. This is often a clinical assertion, not always, but it can be, but it can also represent things where on an admission form, the patient is asked, do you have any allergies? And there's a tick box and they go, no. So what this is about is instead of saying emptiness, because the system has actually recorded something, it's not that they have no information whatsoever about allergies. It's that they have the information, whether it's supplied by the patient or a related person or a clinician, that there is no known X. So no history of procedures, no known allergies, no current medication, no current problems. And that's typically where this goes into in terms of that clinical data. So where a system actually has this data, what we are asking systems to do, and it is a should, not a shall. And this was interesting. I'd like it to be a shall, but the overwhelming kind of feeling I got from people is should, is that you populate section entry. So you supply the actual structured resource here, and you do that in accordance with implementation guidance. So our profiles on allergy intolerance and our profiles on other things all say how to represent this information is missing. And so there's guidance on them, including which specific SNOMED codes to use to represent that there's no known allergies or no history of procedures. So that's the recommendation, is that it's a should, and that this is preferred to using section empty reason. What we're really trying to draw is this clear line between saying empty reason is for like true emptiness, where a system doesn't have anything. Sometimes it's workflow, but where you actually have something clinically relevant and no known allergies is clinically relevant, you're populating section entry. And that's in accordance with the guidance in AU Core. It's in accordance with the guidance in IPS and US Core on how to do this. So that's kind of the first part. And I think we will also state that also drawing a clear line between how to treat empty reason and section entry is something that all the specs are working towards. IPS has got some additional guidance coming out in IPS 200, where they do say that we prefer you to use section entry. So we've kind of put that forwards as a should. And that landed pretty well in the last conformance session, but I'll open it up for comment now. Just seeing a couple of things in the chat. Okay, people have to leave, no worries. Is there anyone whose implementation is actually going to conflict with this? Would this be a problem if we actually state a preference that if you have no known allergies, no current medications, that you are populating composition section entry, and that we have a preference for it? Okay, I'm hearing none. So I guess my question to people is this clear enough to go to ballot? Put this out to the community to say, this is our recommendation, that this is what you should be doing?
think it looks clear
Yeah.
enough, Danielle.
All right, I'm going to motion to approve this guidance on how to support known assertions of absence of data in AU patient summary.
Happy to second, Marika.
Thank you. Okay, we'll give it another couple seconds in the form. All right, I am going to edit now and read out the results. So we have 10 affirmative and 3 abstain, which means the motion is passed. Thank you. Back to you, Danielle.
Thank you. If people are all right, I'd like to just quickly go through well, it's an absence, but it's due to workflow. If we generate quite a lot of discussion, we'll just postpone this to the next meeting. So this is where I was calling out that we've done a lot of work in AU Base, and particularly around supporting some of the gender harmony inclusions. And we'd like to bring that also forwards into AU patient summary around reasons why you might not actually have a list of medications or other content. It seemed a real big gap to us to just straight go, oh no, we're just going to say it's unavailable. And the content we've got here and what we are looking to support is that where your system doesn't have information for a section, and that it's a known workflow reason. So this might have been because prefer not to answer, depending on that section and the information. We've got the guidance here that you can represent it by using this code. This is the code defined and used in AU Base for the same kind of content. We've got where something was asked, but it's not known, as asked unknown. And then we've also got where the workflow itself doesn't actually support obtaining this information. And this is kind of going towards why, like leaning back into where empty sections, we've got a should there for a minute, but it's not a shall. So this might be something that's even appropriate again, of not asked. Instead of just going, there's no information available, depending on the kind of use case or context, even though it's an optional section, the reason you don't have that information is because the workflow didn't actually allow this to be asked. So these are the concepts we're putting forwards for consideration for providing guidance. And I'll open this up for comment here.
Just to clarify, Danielle, is this at the section, you're thinking this is at the section level as opposed to at the element error? Yeah.
Yeah, and I know I've got section entry and it should say empty reason. Apologies for that copy paste.
No stress. I just wonder whether or not this should be a should, so that it's in line with the other options for missing data, just in case asked but declined or asked unknown might give further information away, where using something like unavailable might hide that information.
True. I do think suppressed data trumps everything, though.
Which is why I'm concerned, because this is due to workflow and you've got a shall on this, but I think for suppressed data, this seems stronger than suppressed data, the guidance here, and it seems like it would overrule guidance there if it was both.
I'm happy for that to change to a should.
I think that was my only issue with this guidance.
So 2 changes. One, that should have said composition section empty reason. And this would be a should. Brett.
Yeah, I think also conversely, you may just want to say the data's missing So having this as a should gives you that option as well. I mean, it's nice to know this information, but I know a lot of systems wouldn't necessarily support it.
Mm-hmm.
So I think should is a good option.
All right. Any other comments or questions? All right. If this is clear enough, noting I'll change the should and the composition section empty reason. If there are no other wording changes we need, then I'll make a motion to accept that with the amendments of should and composition section empty reason for the AU patient summary.
Thanks, Danielle. Do we have a second?
I'll second Marika.
Thanks, Marika. Okay, I'll give it another second or two and end the poll. All right, so we have 9 affirmative and 2 abstain, which means the motion is passed. Thank you, and back to you, Danielle.
That's it. We've got through it all. Obviously, we're over time, and thank you everyone for sticking with me to get that entire set done. I really appreciate it.
Thanks, Danielle. Look, I know, as you said, we're over time, but I think it's important we get this done. So I won't put the slides back on the screen. I'll let everybody go. We'll send out some minutes from today's meeting and the material that you can have a look at it offline. So I think thanks everyone for staying with us and just helping us get this one, across the line. And yeah, we'll see you at the next call. So thank you and have a good weekend.
Thanks, Ricardo.
Thank you.
Thank you. Bye-bye.
Bye.